190 peer-reviewed publications. He's written lots of reviews and books, several dozen, and really has an important role in protecting the military and military personnel from infections around the world. He developed the Ebola training course for medical personnel who were going to be deployed to Liberia, and I was speaking with him a few minutes ago, and he assured me that there were no cases of Ebola among those individuals who participated in his course. A couple of cases of malaria, but no Ebola. So we're delighted to have you here, Colonel Murray, to speak to us about the management of infectious diseases or infectious disease complications associated with disasters and humanitarian crisis. Let's welcome him, please.
It's really great to be here. I always love the first row, always is well used. And eating cookies in front of me is a little mean trick, so thank you very much. So what I've been asked to do is sort of talk about a perspective of disaster and humanitarian missions. More importantly, the recruiting command asked me to come up and do this along with the WashU. And I'm not here to recruit you. If you're not already in this uniform, sorry, it's the gig going. You'll sort of see why. But if you do have questions about a career in the military afterwards, let me know. And I can at least tell you what I've done over my 22 years in the Army, and you'll see some of the fun I've gotten to have along the way. But I think it's important up front to sort of set the stage of what we're going to highlight. And I'm going to give you a picture of why a Department of Defense person is standing up in front of you giving you the story. Clearly, I'm a person that's been in Iraq and Afghanistan more than once. Clearly, I've been taking care of casualties on the battlefield all the way back to San Antonio, where we're a level 1 trauma center that takes care of burn patients across the Department of Defense. But what's really our role in humanitarian and disaster medicine? And to give you that flavor. And then from there, transition to how we link to the global community. And as we shrink from the global community to the national, and from the national to the regional, and keep drilling down, I'll sort of give you that flavor of how we fit that picture. Talk about generic complications that we have from disaster medicines and sort of a big picture approach to them, and then drill down even further into the infectious disease issues we have and sort of the concepts to be thinking about. So in the Department of Defense, basically we have one boss, and that's the President of the United States. So they are following what he tells us to do. Every year he comes out with a document that says, here's my national security strategy. And it defines what our focus is as a nation and our impact around the world. As you drill into this document, you can see there's some major important emphasis. It's not just be a land mass battle organization. We highlight things like going to Haiti, going to Japan, the typhoon. We're actually in the process right now of rebalancing to Asia. So despite all of our efforts over the last 14 years or so, mostly being in the Middle East, there's a direct emphasis of us shifting our efforts into Asia for all sorts of reasons, humanitarian regions, economic regions, global security regions, and you're going to see that. More importantly, you read this document, and there are specific sections now that talk about our global health security. And what that's related to is not only Ebola, but they talk about multi-drug resistant bacteria, they talk about HIV. So at the national strategic level, meaning the President of the United States and Secretary of Defense and State, these are conversations and they recognize how important this is. When the President releases their documents, the military takes hold of it and says, how does this apply to us? And this is the national military strategy, and the most recent one out in 2015. At the top are our enduring interests. It's what's been going on forever, really haven't changed for 60 years. From there you look at our security interests. From there you look at what the military is doing. And our focus is on state actors, Russia, China, things like that, non-state actors, extremist organizations, terrorist agents. And then after that, it's really the global community and how do we partner with folks around the world. And we look at this from a joint perspective, meaning the Army, Navy, Air Force, and the Marines, and the Coast Guard. How do we do what our nation wants us to do? And you can look at this list, and all the way down at the bottom is humanitarian assistance. We know that is so important from a stabilization globally, but it's also what we're supposed to do from a profession, is recognizing how we help more of a global perspective. And this is exactly what they say, is you need to be able to respond. You need to be able to respond really fast. You may be there a week, you may be there a day, you may be there 3 months, you may be there 6 years. It really depends upon what the mission is and what is the need from our national security perspective. And this gives you a flavor of where we are right now. So the teal, sort of the United States picture, that's more than 1,000 folks. Sort of the A little bit sort of in between blue color is between 100 and 1,000, and then the darker blue color is less than 100. Where are we? We're everywhere, right? So if we're in an embassy, we have Marines at the embassy, but most of this is civil affairs where we're going in and doing nation building. This isn't I'm wearing a gun and I'm shooting people. This really is, my focus is building the nations to support them so that they are stable, so that we don't have to go in from a combat perspective. Those of us that have been in combat really don't ever want to do that again, so everything we can do to prevent that is what we should be doing. As you continue to look at what we do from a military perspective and you come down to what a doctor does, this is what we do. So we do operational medicine. What that implies is I leave my family and my career in San Antonio, and they send me places where I take care of a soldier downrange, or I do disaster medicine, or I do research on leptospirosis or malaria, so that I'm really sort of supporting those that are going downrange. Also patient care. We are designed to be able to do point of injury care, which means this person got shot, do I know how to stop their bleeding? Can I stabilize them? All the way back to multi-drug resistant infections in our burn patients. That is the gamut of what I practiced in my career, and those are the skill sets that you sort of have to develop. From an education and training standpoint, we have about 4,500 medical corps officers in the Army. At any one time, a quarter of them are in graduate medical education. Just like you, I have 95 internal medicine residents at BAMC, following the same crazy duty hour rules that y'all have to, the same 1 in 7, and interns, do y'all take naps here? No? I mean, it's actually written in the rules. You can take a nap if you stay too late. So everything y'all do, we have to do. And there's a huge emphasis on that. But at the same time, we have to make sure we're giving them some military unique training. So these are the things that we do with them. From a research and innovation standpoint, very similar to what y'all do. What are the patient populations you see? What do you struggle with? How do we emphasize that? So when we pick our research, it's really focusing in on care downrange. What do they come back with? What are the infections they're going to wrestle with? And that sort of perspective. And this is my approach to Army medicine. So the red stars is where I've had the Army pay my trip, just like this one. They put me up in a very nice hotel like the plaza down the street. That's where I'm staying. That's a sweet hotel, in case you're curious. They have a movie theater in that hotel. It's bizarre. But they've also sent me overseas, so I've gotten to go to Canada. That was sort of fun. I've got to hang out on the Amazon. I've gotten to be caught in the coup in Congo. I've gotten to go up and down the Nile. And I've spent extended periods of time in Iraq and Afghanistan, because that is really where we're needed from a military perspective. And those operations include being in combat, to disaster medicine, humanitarian missions, research, a little bit of everything. So it really has been an amazing experience. This is what most folks think we do. This is my time in Ramadi, Iraq in 03 and 04. Basically 2 convoy briefs, which means you sit in a huddle, you talk about where you're going to go, how you're going to get there, and how you do it safely. While they're having these 2 briefs, 2 mortars come in and land in the middle of both of those convoy briefs. 43 casualties immediately at 1 o'clock on a Sunday afternoon. Sort of terrifying. I had no surgeon to help me. Is there any nephrology wannabes in the room? No? You don't want to admit it out loud? Okay. So basically, it was me and a nephrologist doing a mass cow with 43 people. Can you imagine an ID doc putting in 43 chest tubes in about 2 hours and putting down central lines and cut downs? That's what we do, right? And these are the type of mechanisms of injury that result from this. So this is Master Sergeant Robles. He's a patient I've been following since 06. He has a chronically infected lower extremity from his stump. He was able to put the first tourniquet on his leg. He then passed out. His driver pulled out his tourniquet and put the tourniquet on the other leg. What saves our folks from trauma? It's bleeding, right? So we don't do airway, breathing, circulation. We do bleeding. And then we do everything else. So when you think about disaster medicine and trauma, that's really going to make a big difference. He's great, right? So he gets his legs. He has a good time. He's crazy, in case you're curious. So has anyone gone alligator hunting? You don't want to admit that either. So alligator hunting is you walk with a pistol, alligator's there, a little water, you walk along the side, you shoot said alligator and pray you kill it because they run really fast. So that's what he did. He went big game hunting in Africa, and then he is part of a hockey team. He wasn't on the hockey team that went to Russia, but he went to support our hockey team with a lot of our bilateral amputees on that team. So folks have massive trauma and completely recover and do well. But the disaster associated with war wounds is very much a parallel with an injury you may see in a tornado, or a crush injury being caught in a building in an earthquake. We also do an awful lot of humanitarian missions. We did a whole lot more in the past. And what you not only got to do from a local country standpoint, you got to help them, but you also got to learn their healthcare infrastructure, their personnel. But you also got to figure out, how's that CT scan going for that spleen exam, right? So my spleen exam is awesome after I get a CT scan that tells me it's big. And then I go in and I show the medical student, see, it's right there, right? It's completely the wrong direction. But if you don't have a CT scan, you now have a stethoscope, not an echo, and you have your hands. So life is incredibly different. Fast forward to a natural disaster and you have no electricity. How's that CT going to work for you? Same scenario. So as you relate these things, there's some real nice parallels that train you for stuff. You also got to see the difference between their health infrastructure and ours. So that's the Peruvian military's hospital ship. If you've seen pictures of our hospital ships, they are massive. 20, 30 ORs are inside of these hospital ships. 2 inside of that one, right? So if you have to walk up this embankment with all your stuff, that works pretty well. Sometimes you can't get up the embankment, so you bring the patients down to you. Do you think that's any different in a natural disaster? If you can't get out to them, bring them to you. Much easier to bring them inside the hospital, but sometimes you can't. So you fast forward, you put that EMS in there, you put an emergency medicine doc, a critical care doc, a surgeon on the back of that ambulance, and you push assets out. And those are things that you can sort of develop and think about if you're caught in a natural disaster. At the same time, think about how you're taking care of them. So that's a microscope. Everyone's using a microscope in here. What do you have to have it work? Electricity, right? So no electricity, no microscope. So you get your mag flashlight, you put it in the back, and you shove it up front. If your generator gets knocked out from a natural disaster, can you imagine putting a central line or a chest tube in 2 o'clock at night dark, right? You get your headlamps out, you get 3 other nurses and medics, corpsmen, assistants. Everyone's got their headlamp on their head. They're all looking at the same hole so you have enough light to see. That's what happens when you have a natural disaster, because you lose the basic infrastructure that we are incredibly used to having, which really can be a challenge. From a medicine, I never thought about it. My kids got an antibiotic. They gave me some powder, I mixed it with water, I shook it up, I put it in the refrigerator. So if you're getting water that's contaminated, how's that antibiotic going to go for you? If that refrigerator doesn't work because there's no electricity, an entire way you've been managing goes away. Historically, when I give kids antibiotics, I have to know how much they weigh so I can dose modify based upon weight. How's that scale that you didn't bring go for you, right? So now all of a sudden you're continuing to sort of think about life in a very different perspective when the infrastructure goes away with a natural disaster. If it hits your hospital, then there's a huge issue, and I'll show some stories about that. When we're thinking about natural disasters, you have to wrestle with how you're going to either get them to you or get you to them. So in the upper left is the bridge over the River Kwai, not quite the one they blew up, they rebuilt it, pretty amazing. But if that's the way you have to get in country, that's a major issue. This is the Amazon during the dry season. This is where the water would be during the wet season. So if you thought you were going to get up that tributary because the water goes all the way up, and then you show up and the water's dropped 95 feet, guess where that boat doesn't go anymore, right? So if you didn't have a plan of putting it on your back, it's not going upriver for any natural disaster. And you can fast forward that into the U.S. If those bridges are knocked out, that road you can't get because it's been washed away with the flood, life drastically changes. This is a road going over a mountain to get to another village. You got to be ready to get out and push that truck through that mud to get your healthcare system to them or the patients to you, which can be an issue. This is a helicopter riding in the back going from place to place. Think about the personnel you're with. So for my time in Kenya, they mixed cow dung with dirt, still put it on the wall. That's a different environment from what I'm used to. No air conditioner, no electricity, no nets. So now all the diseases that are endemic to Kenya, I'm now being exposed to because I didn't bring the right stuff for my response team. We also do an awful lot of research in the military to answer these field expedience questions. So there's only one FDA-approved malaria rapid diagnostic kit. It's like, a pregnancy kit, put some drops of blood, some reagent, close it, 15 minutes later you read it. And this was developed through the Army and the Navy in Peru and Thailand. But it's great for Vivax and falciparum, hasn't been validated in oval and P. malariae. So if you're going to West Africa, that's an issue. Leptospirosis is a research project that we spent a lot of years on. When we've done FUO studies, or fever of unknown origin studies around the world, what we basically showed was about 10 to 20% of them ended up being lepto. So lepto is spread by abrasions being contaminated with water that has urine from animals. What do you think happens in a disaster? Where do the animals go? To the same place you're going. And now you have abrasions all over the place. So do you think lepto starts moving up your list if you're going to a high-risk area? And that's really how you sort of have to start thinking about this. What's different as you're moving around the world? This is our experience in Ebola. This is actually the Congo. That's the Ebola the river it was named after. This is me giving talks. And really, 3 days, I had to develop an entire 3-day course to go and teach 250 healthcare providers spread across the East Coast to go downrange, not from an Ebola standpoint, because we didn't take care of any patients, but how not to make ourselves sick and how to make sure the 2,500 soldiers we went with did not get sick. For me, it was an incredibly rewarding experience. Both of my parents grew up in Africa. They were missionary kids. My dad, which is there, didn't speak English until he was 6, spoke Chaluba. So my parents would speak Chaluba in the house. They didn't spell. They just spoke some crazy language when they didn't want me to hear about it, which is sort of bizarre. But my aunt still lives there. She's actually at home in Texas for about 2 weeks, and she's going back tomorrow. But it's an amazing way to connect life. And I got to go back to Congo to do some research in Kinshasa, sort of closing these loops. But I can tell you, when the Ebola scare happened, hey, is your aunt infected? I'm like, Congo, Liberia, right? So there's this big difference in the map that people just don't understand. So when you're thinking about the granular information, you've got to drill down far enough that you're actually knowing what's going on in the countries that you're going to be visiting. I think it's also very important to recognize from a Department of Defense standpoint, when we went to Liberia, we were not lead element. State Department was. So USAID was lead element. That's who was in charge. So when you walked into the room, at the front was the embassy representative, because the embassy lets us in countries. 4 chairs down is the 2-star general. Now, how do you think that does for our egos? Because doctors are arrogant. Imagine being in the military. Crazy arrogance. So it is a big deal when all of a sudden your bosses are in a very, very different lane. And that is very true for lots of disasters. You show up, and all of a sudden, it's a state-run organization. It becomes a federal emergency, and now FEMA's in charge. And how do they interact with the police and the EMS and the physicians and the healthcare providers? All of these are at play that really can make this a very difficult conversation. So in the DoD, what we have to always make sure is we're looking globally at how we interact with what is standard of care in a country and in a region and for the WHO. Because if you really go against the WHO and we unplug and move out and go somewhere else, if we leave a wrong infrastructure, we failed, right? We have to give them what they need, not what we think they need. So a lot of time is spent working with the WHO and making sure we do the right thing. This is the most recent publication from the WHO looking at disaster statistics from 2009. It's sort of nice because it starts to frame things into a concept that you can say, here is the type of disaster, and now we go from that type of disaster, what are you likely to see? So is a flood different than a tornado, which is different than a volcano, which is different than an earthquake? Each one of those, in your mind, you can start developing a differential diagnosis of the type of trauma or the type of infectious diseases you're going to see. And you can also start looking around the world and trying to get a handle on what regions are high risk and why. And once you start to figure that out, now you can start preparing ahead of time. Because when do you really not want to be working on that disaster plan the day it happens? You really want to have something in your hip pocket you can pull out and really have a response. And I think lots of these things, there's probably an 80% fix for most everywhere you go. And then you just fine-tune the last 15% with the exact endemic disease you're going to wrestle with and the type of disaster. You can also drill down and start getting a flavor of what happens around the world. So in the Americas, it's a little bit different than in Asia versus Europe. So that flavor starts to tell you what you should be worried about. At the same time as we worry about natural disasters, we also substantially put a lot of emphasis on the UN High Commission on Refugees. Refugees are a major issue with destabilizing regions. And where do you think the military goes? We go to destabilize regions. So Syria, Afghanistan, Somalia make up 53% of the countries that provide refugees. Turkey, Pakistan, Lebanon, and Iran are the countries that are receiving refugees. In the media lately, right? You hear about this lately? It's a big deal, right? So when you start destabilizing country, we talk about black zones, and these black zones are where it's just lawless. And what happens in lawless areas? People don't do well medically, and terrorist organizations form in these, and bad things happen when there's no government sort of giving you some good right and left barriers. And that's why the Department of Defense gets involved in things like this. But fundamentally, when we're wrestling with disaster and humanitarian missions, there's sort of two major problems. There's a climate issue, right? So it's really wet. There's lots of vectors. There's lots of endemic diseases. And then you look at the environment they're in. Many of these folks are right on that cusp. I'm okay till I'm not okay anymore. And if I fall off the I'm not okay anymore, that is the issue we struggle with. Poverty, sanitation. How do you get them back up on that pinnacle is really, really difficult. So if you can prevent them from ever falling off, life gets a whole lot better. In the DoD, we have a manual for basically how to go to the bathroom, it feels like. It is insane what we have. So this is a disaster response staff officer handbook that sort of walks us through step by step. You go here, this is what you should do. This is what you should take. This is the power requirement. Here's how much water you should do. Because it gives you something to hang your hat on so you can actually get over there and do that. This document is mostly focused on the US, so you can actually drill down by county and actually what kind of disaster was in that county and what the issues were, and then did we actually activate a state response, a federal response, and then what actually happened when those happened. They do the same thing in our DoD documents. We don't actually want to completely replicate the WHO. Why? I don't know, but we can't. It's some unwritten rule out there. But they still sort of break it into the same concepts. And then from the same concepts, they talk about the same type of complications. From complications, what do you actually do? So as you continue to drill down, we start to then sort of, as you go to the WHO, we'll look at the CDC. And if we're having a response in the US or globally, we'll try to make sure we're lining up with both of those organizations, because we do not want to go it alone. We want to make sure we're looking at the civilian community and the military community and doing it the same way. CDC has some very nice information. You can drill down into tornadoes. And within these topics, they can give you information for healthcare providers, what vaccines, what drugs, sort of the concepts that you really need to be thinking about and developing before you sort of go to your new mission. FEMA, Federal Emergency Management Agency, has a very nice webpage where you can actually start really drilling down. So now I can click on Missouri, and I can tell you since early 1953 how many disasters occurred in the state of Missouri. Continue to drill down and click on St. Louis County, and I can tell you per month and per year exactly what happened. I can click on it, and it'll give me all the FEMA information that's related to that disaster. Whether it's ice issue or a flooding issue or what have you, you now start to get a flavor of what I'm actually going to wrestle with in this region. Right? And you can do this anywhere, which is really sort of a nice picture. And then you can keep drilling down. Now you go into your state responsibilities, so you can look at the Department of Public Safety. Missouri actually has a very nice webpage that sort of walks you through the disasters, walks you through the complications they've seen. Doesn't quite get into the meat of actually how to do it as a healthcare provider, but at least gives you the framework of how to do this. Illinois, their emergency management agency, everyone has their own name. They're more focused on terrorisms and weapons of mass destruction, radiological exposures, chemical, where the Missouri clearly had some very nice natural disaster humanitarian assistance approach. So there is even a flavor within the states. And then everyone can drill down from a state to a county and a county to a big city. And then you just sort of work up and down based upon what information you're trying to get. So that gives you a flavor of what the DoD's involvement is, and then we try to relate to the global community in making sure we're in line with everyone else, so not inventing something new, really trying to answer this from a different perspective. As you move from there into type of disasters, that's where we start to put the framework around what are you going to see and what do you need to be ready to manage when you're there. And we think about sudden disasters. We think about human factors, so Chernobyl, right? Radiation leak, close down a town. How do you get all the pipes back into a nice protected area? You can have a pesticide plant. Let's just go to China and the 2 factories that have blown up in the last week. You know, what was in those big giant factories could be really bad if you can't get in front of it, or you spray water and makes the chemical more reactive. Bad decision. So just think about how you're doing this. Also, insidious disasters, drought, famine, long-term leak, and what about this issue of global warming? This is now such an issue that it is written in our national security strategy and is written in our national military strategy. If the water level really rises 9 feet, what's Miami going to do? What's New York City going to do? What are lots of the international cities that sit right on water and the world 9 feet higher? That's a huge struggle that we're not sure what people are going to do. But you can see when people start having their houses destroyed and they're not able to live in the same home anymore, that's when things become disastrous, which is why the military is looking into this to try to figure out what role we have, not to fix global warming, although we're doing more green in our places than you can imagine. But that is an emphasis that we're thinking about from a threat perspective, which is a very different perspective than probably lots of other people look at it. So then we look specifically at natural disasters, and this is a no-brainer, right? And the classic example is in Joplin, Missouri. You know, that massive tornado that went through and basically wiped out a city. This is an interesting read by an emergency medicine physician who was working the night that this happened. He talks about the cell phone service not working. He talks about the electricity going out and doing procedures with headlamps. I mean, it's an insightful little article from a humanistic perspective to let you know what's going on. But lots of the lessons that I had earlier in a disaster environment or humanitarian and austere environments can now be moved over into an environment like this. There's a difference. If you get rid of all the infrastructure, you got no infrastructure. It doesn't matter if you're in the US or you're in the middle of the Amazon River. We talk about long-term impacts. If I destroy your crops in the US, you just go down the street and buy seed for next year. If I destroy your crops in the developing world, that seed is what they were going to use next year. If there is no seed, there is no crops. Now the UN has to come in, the US provides this. Those are issues that we don't sort of think about from our perspective because there's a grocery store down the street. Just go get it for next year. Very different things. And as I mentioned earlier, as you start to degrade your healthcare system and now your sanitation system, you know, we can sort of pull someone out, fix that leak at the house relatively easily. We don't like paying $1,000, but we'll do it. This is a very different discussion in different parts of the world. Historically, we've risk stratified folks into Asia as highest risk, and then Africa, South America after that, and then North America, Europe, and Australia after that. But how about Katrina? Really? That didn't go well, not even a little bit. Right? So read stories about people's experience inside the Superdome. You know, people claim we didn't get water to them for 5 days. People claim there was sewage and feces and just disgust everywhere inside that building. That's where they lived, right? I was doing a mission trip with my kids' church about 3 summers ago in the lower 9th Ward. There were still buildings that had the cross on them, which if you look in these different sections, they talk about number of dead people we found, number of times we visited this body, number of dangerous chemicals in there. Still on the buildings, and 10-year anniversary was last week. These are things we are still struggling with, and even though we were there 7 years after the event, we still had work that they needed us to do in the lower 9th Ward. So these things can have a lasting impact that we don't appreciate effectively, even in the U.S. If you look at the most recent data, these are the numbers. $41.3 billion. Sound like a lot of money? Not even chump change. I mean, we talked about $41.3 million in the military as a tomahawk weapon, right? I mean, that is not a lot of money. On the other hand, if you're in a country where your family earns $1 a day, so you're at about $400 a year is your entire family salary. You think 41.3 million or billion is a lot of money? It's crazy money, all right? So there is a perspective that I think we lose in this country, that we have to continue to redirect our mindsets when we're talking about how we help other places. And what costs us lots of money is a very different concept of what costs other countries lots of money. From a future perspective, from a disasters, we think we're moving into more high-risk areas. Texas, we've had more earthquakes in Texas for the last 2 years, and we don't know if it's fracking for oil or the drought. Everyone's going to blame someone else. But clearly we're seeing shifts in what we have historically been experiencing for the last 30 years that I've been there. We're also having disasters in very remote areas that are very difficult to get to. So if everyone's moving to the city and then I have a small little town that gets hit, their infrastructure is not what it used to be. So we think this is going to be an issue globally that we're not quite sure how we're going to handle. The other group that we think about a lot, in addition to refugees, is this concept of displaced persons or complex emergencies, which links really nicely with refugees and this term internally displaced. So internally displaced are the government doesn't like you, but you weren't able to get outside of the borders. That's a huge issue, because if you get outside of the borders, the UN can help you. If you're still inside your borders and that country doesn't want you in, UN can't come in. I can't come in the military, the embassy won't let me in. So there's lots of issues between internally displaced and externally displaced. Sort of a classic example, and you can read and watch some movies on this, is Somalia, 1993, Black Hawk Down. Pretty amazing story. So why did the DoD get involved? 2 reasons. One is there were a lot of terrorist camps that were being built, and a lot of people that were there that were in Al-Qaeda that we were trying to engage with. At the same time, the non-government organizations called us and said, we need help. Non-government organizations hate us, right? So when I walk in a room, I look funny, I carry an M16, I am big, I am ugly, I am not what you want to see if you're trying to build goodwill, right? So when a non-government organization calls me into the room, they're basically saying, it is so unsafe, we need you. And logistically, you have planes and helicopters and vehicles that we can't use and find that you bring to us. So this is a huge deal. Anyone work with Doctors Without Borders here? An amazing organization. I work with them sort of code behind closed doors in my civilian emails because they do not ever want to know that they work with us because we bring such negative baggage to their organization that doesn't happen. Liberia, what happened? We're sitting at the same table, having long debates for about 3 months. That just does not happen until the infrastructure and the system becomes so unstable, they understand there's certain things that the DoD brings to the table that no one else can. And we know that. Truthfully, that's not my job, is to go do humanitarian missions in small groups all over the world. We go when we really are needed. So if it can be handled at different levels, that's really the way to do it. So these complex emergencies really follow a typical pattern. Country starts to destabilize, things start to get to pot, and then they start targeting populations within them, which can really be an issue. And then you start really undermining everything that's going on in the environment, and that includes healthcare, that includes public utilities, that includes food and water. And now you start targeting people because you can use people to influence other people. And this is really when those internally displaced groups get in trouble. And those are disasters. They're massive disasters on levels that are unimaginable. And the refugee camps and internally displaced to a degree are able to monitor these, and you can just look this up and figure out how many beds you need, how many tents you need, what's the water system you need, things like that. So as you transition from sort of the natural disasters, now you start to look at what do you actually see during these natural disasters. So floods are, without a doubt, the number one out there. So about 70% of the major floods occur in India and Bangladesh. Lots of fast-flowing water, lots of trauma, drownings. Even in South Texas, we had a big, massive flood where people's houses got knocked off their base, and people drowned inside the houses in the last 3 months. So this happens everywhere. The difference is we typically recover much better in the States, but I've already shown you Katrina, maybe not so much. Of the people who survived, very few actually need medical care. You either made it or you didn't. And what do you mostly need? A little bit of ortho, some cuts, some scratches, some things like that. So very different perspective. I'm going to bring a full-up surgical team in an ICU. That's what they necessarily need. Snake bites becoming an issue. They're going to go to the same place you are, which is dry land, unless they're a watermelon. And then they're going to go where you are because you're stuck in the water. Think about the break-in oil. Gas. Yeah, I don't like moccasins. Sorry. Gasoline. So all these things are floating through the water, hitting things they don't normally hit. And now all of a sudden you have fires and leakage, and the water becomes more contaminated with not just human sewage, because the water gets into all of our plants. You're now mixing oil and everything else with that. So this just continues to compound itself. Tropical cyclones, hurricanes, typhoons, these are the ones that wipe out entire cities, 250,000 in a single event. Same thing as flooding, that's the issue. So the storm surge is where the locations come from, not necessarily the high winds, but you're going to still see lots of trauma just like other things. Once they then get settled, they all go into areas for storage, and now I have issues with fecal oral contamination, respiratory infections, flu, adenovirus, things like that. If you put your nuclear reactor right next to a flood stage area, right next to where a hurricane hits, how well is that going to go for you? Not well. So where's nuclear reactors around here? What is the plan for responding to that potential natural disaster where a tornado wipes through a nuclear reactor? Different game plan. If you don't wear those little funny suits all the time when you go into these environments, this is not the day to start. In tornadoes, I grew up in West Texas, a town called Lubbock, Texas. What we did in high school for fun is we chased tornadoes. Stupid, let me tell you. But we always knew tornadoes started here and it always went this direction. Always, 100% guarantee. You know how this goes. So what do you do as a high school student? You put the car here and you just travel this way. And you try to see if you could keep up with it. Don't do this. Yeah. I have a 17 and a 19-year-old now. I am so terrified they did the things that I did growing up. And I just don't ask anymore. So when you think about tornadoes, think about that wind, think about that vacuum in those spaces. Massive, stupid to chase them, but massive energy is associated with that. And I just showed you pictures of Joplin and what it actually did to entire blocks, just wiped them out. What are you going to see? Penetrating trauma, blunt trauma, classic trauma-associated environments. This is interesting data that looks at unique infections from tornadoes, right? So the Joplin tornado had an infection with a specific genus and species of a fungus. Well, what's our experience in Afghanistan? We see the same infections. What's the difference? This is massive trauma from a tornado. For us, it's you're walking with your body gear, you step on a landmine, it blows this arm off, it blows this leg off, and it blows this leg off here, and it blows fragments up into your pelvis. I didn't take you to a surgeon because I put tourniquets and you don't bleed out. And they use 200 units of blood product support in the first 6 hours on you, right? Do you think I can keep you on the OR table to completely debride all those wounds and get all that stuff out? And where are they walking? Well, they're walking through waterways. What kind of waterway? Poppy seed waterways, right? So big, lush vegetation is now blown up into your wounds. I give you antimicrobials, I get rid of most of your bacteria. Next thing I know, day 5, 8, 10, you're massively infected with a fungus, right? What changed? Environment, meaning I'm now walking in lush vegetation and massive injury patterns. So you can see parallels as you sort of walk through all these things. From a volcano standpoint, lots of gases, lots of mudslides. Think about reactive airway disease. Imagine those pictures of 9/11 when the buildings collapsed in New York and all that dust that went everywhere. Can you imagine reactive airway disease in a similar environment with this? If you're not having a bunch of inhalers with you, all of a sudden this becomes a major struggle that you weren't thinking about. Earthquakes, again, heavy dust and trauma. So these are consistent stories over and over and over. Management, simple, speedy, feasible. You may be carrying it on your back, so therefore you're not really planning on taking that CT scanner and that 25-bed OR response team. That's just not what you're doing. Early on, this is water, this is food, this is shelter, and some cuts and scratches. Later on, life becomes much more difficult. But early on, this is not a huge infrastructure. What you're going to start doing is collecting data and looking for your high-risk patients. So you're going to start getting baselines and then look for the kids. And there's data that says females do worse, probably regionally as much as anything. But these high-risk populations that don't do well, you need to sort of figure out how you're going to protect them. Otherwise, you're defeating them actually there. Other things that we've seen in our disasters that most of us just didn't think about intuitively, not only are the injuries an issue, but sexual assault's an issue. Psychosocial problems become an issue. And do you think PTSD isn't an issue? So how many people think the response team to go to a disaster should automatically be a psych unit? Maybe it should be, right? So I got my docs that are doing the healthcare right there, and I got my docs and my behavioral medicine teams doing their stuff too, working in parallel, which is now what we do, because we think it's that important. Relief measures, you got to think about food, right? You got to think about water. How much water? 15 to 20 liters to bathe, cook, and drink for a family? You know, these are things from a logistical standpoint really become a nightmare. So you may have the idea that you can get in there and help, but maybe can't. What we do really poorly is recognize sometimes we aren't always a benefit. So if I show up to a natural disaster, and I'm a good young college student, really motivated, strong, can work really hard, they're going to say, huh, where's your food and water? I didn't bring any. Where's your sleeping bag and where are you staying? I didn't plan for that. So what vehicle were you going to get upriver to take care of the town that's been demolished? I didn't do that either. So now all of a sudden, what's that college do? It's a burden, right? You now are sapping resources and not actually pushing anything forward. So you have to really think hard about what you're actually bringing to the event to make it go the right way. And really, data drives this. So you're trying to get a baseline. If you start having bumps and acute respiratory infections, diarrhea, things like that, now you can intervene. All of a sudden, you're just waiting for the rumor mill to get to you. You may be too late because you can't be everywhere all the time. So primarily from a prevention, big picture stuff up front. And at secondary, you start to drill down a little bit tighter. And tertiary, you continue to drill down, and now you're starting to really sort of move into those infectious disease issues of what you can actually do to prevent some excess morbidity and mortality. And to get that information, you need to figure out where you're going, right? So what are the endemic diseases that are different than what you should always see with a flood? And this is ProMed. It's a really nice site. It'll give you a map just like this. This is 2D. You click on that circle. It gives you all the infections or issues they're wrestling with plants, animals, and humans. And now you can start to drill down in some acute outbreaks. At the same time, you can go to a state program and say, what are your reportable diseases? And what do you see, right? So you see Ehrlichia here. Do you see plague here? Do you see Vibrio here? You know, what do you see in your region that needs to be on your differential? Because all of a sudden, what was always being seen in your hospital is not your hospital anymore. It's a new hospital. What is the endemic resistance profile of your new world? Most of us think about field labs, things that you can carry on your back and clinically available. You're not going to have a CT scanner. You're not going to have a CBC machine. You're not going to have a chemistry panel. You're not going to have an anion gap. You're not going to have PFTs. You're not going to have a chest x-ray. You're not going to have it, right? So all those things clinically that we learned as a first-year medical student is really what you start to apply in environments like this. Malnutrition is a massive issue, your increased risk of infection. So when you start looking at your folks and go, wow, you're all 10 to 20% below ideal body weight, this is bad. You know you're really on that edge, and you got to make sure you don't push them off in the wrong direction. Things that we have learned through time, we got to make sure you do right. So you're going to see lots of children. So how do you weigh them? And how do you make sure that refrigerated fluid works? Or you get something else, right? Think about how you're actually going to dose. 4 times a day is tough enough, but if they're out there working 12 hours just clearing their fields and moving their house, they're going to forget to take those 2 doses in the middle of the day. So really try to be selective on this. Consider eye drops. We were burned going into a village, had massive outbreaks of conjunctivitis, and we didn't take any eye goop. What do? You go to the next village. I mean, that's really about all we could offer. It was not very helpful. And then think about how you're packaging this. If you write TID on the outside of a script, it goes to a pharmacist, it goes really well. If you write TID and you give that package to your patient, they have no idea what that means. If they don't speak English, they have no idea what that means. If they're illiterate, they have no idea what that means, right? So there's a conversation piece that is very different as you're moving across regions and around the world. One of the things we always try to struggle with is controlling crazy. And what we try to control is there's not an epidemic of cholera and typhoid every day, right? Stop the madness. That being stated, people from Nepal came to Haiti and started the cholera outbreak, right? So that was us trying to be helpful, global community, and we changed Haiti by giving them cholera. Probably not an ideal way of doing this. In developing country, you got to think about sort of the fecal contamination and endemic diseases. Everyone wants to burn all the bodies or put them into mass burials. Not from an infectious disease perspective. Psychosocial, maybe. That's a different question, right? But from disease control, I don't need to do this. People also want to start mass vaccination programs. Also, not needed. Not what you need to be doing. So just sort of a different emphasis. Early influx is diarrhea, 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 right? You'd hate for norovirus to get in there because norovirus is almost a nightmare to clean. And that goes and knocks out, we've actually lost complete field hospitals in Afghanistan and Iraq because of norovirus. They were non-functional for 3 days. Well, 60% attack rate happened in those hospitals. Crazy, right? Vector-borne diseases. So if you go to regions with malaria or dengue or West Nile, right, or chikungunya, what are you thinking about? How can you control these environments? Think about overcrowding environments. So if everyone's moving into the gym and you're putting everyone right next to each other instead of head to toe sleeping, and you put a certain number, 18 inches between bed, but you don't have room for that, so you cheat. All of a sudden, all these acute respiratory infections become a major issue. Measles can be a huge issue around the world. Not here as much, but it still can be an issue. And then TB, you don't really want to get sick yourself, so you have to think about that. HIV, cocci. So let's say you go to Mexico after they have an earthquake, dust and everywhere, blown through the air. You then leave and you come back to St. Louis a week and a half later, you have a wicked cough and chest x-ray pneumonia. It looks like abnormality, right? Here's your doxy, here's your fluoroquinolone, here's your azithromycin. Nope, here's your fluconazole, right? But your endemic diseases are the ones you have to be thinking about for the region you're going to. The diseases that make us the most nervous are the ones that have a high R naught. What an R naught is basically, I give it to you is an R naught of 1. I give it to you 2, it's an R naught of 2. I give it to 18 of you, it's an R naught of 18, right? So when we think about measles, it has an R naught of 15 to 18. So this is why you go to California in a park and all of a sudden a bunch of kids come down with measles. Because you have to have so much herd protection. That means your vaccine efficacy rate has to be 95% for you to get a population protected. In Ebola, it's about a 1 to 1.8 to 2.2 R naught, right? So we basically said, you put 60 to 80% of your folks inside our Ebola treatment room units, this is going to melt away. And most of us are going, really? What about the other 30% that's just walking the street? Well, because of the R naught, you're going to get in front of the curve, and eventually you're going to sort of defeat this. So if your disease in your area has R naughts that are really starting to move to 4 and 5 and 8 and 10, life becomes a real big challenge. From a skin and soft tissue infection, staph and strep, during the experience in Katrina, Vibrio vulnificus became an issue because that's just a regional pathogen. Atypical mycobacteria has occasionally been seen. Eromonas, sort of a Pseudomonas water bug type environment. Milioidosis is a Southeast Asia bug that actually has relapses 15 to 20 years later. Fungal infections that I sort of talked to you about. And then tetanus. You can't forget about that. So the big massive earthquake in Pakistan, massive number of tetanus cases that we managed. Not that we were on the other side of the border, but we were on the other side of the border assisting in these responses to sort of control these types of things. From a flood perspective, really this is diarrhea pathogens, so don't forget about E. coli, don't forget about Salmonella. Cryptosporidium's on that list. Hepatitis A, most everyone has the vaccine in the US right now, so that's not an issue, but in other countries, probably they've mostly been exposed to hepatitis A, so they're probably immune. B is the same story. Either you've been vaccinated or a huge exposure when you were a little kid. And I highlighted leptospirosis earlier. Priority measures, water, 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 sanitation, sanitation, sanitation. That's easy. That's sort of leaders do that. After that, you start your healthcare services, diarrhea, acute respiratory infections, endemic diseases, wound care, think about your drugs. After that, what you start doing is messaging, right? Wash your hands, boil your water, do the good stuff, right? That's the messaging you start doing so that you can get in front of this curve. From there, you start to make sure you have a surveillance program that's actually kicking in and that you're doing it right. So in the Army, what we do is we do a roll-up every day of everyone in our units that are sick, and then we roll it up once a week, and then we roll it up once a month. So we can actually look for trend lines that are acute and trend lines that are sort of chronic. And those are the things you're going to be doing, especially if you're in these places for a long period of time. Think about your samples. So if I just knocked out your reference lab, or I can't get to the reference lab, what are you going to do? No PCR, no serologies, all goes out the door. How do you get that patient to that CT scanner? What are you going to do with that acute belly? You're just going to open it? That's what we do. different things. And then think about immunizations, very rarely knee, but occasionally you have to invoke it. And then think about your endemic diseases that are vector-borne. Either control the vector, meaning kill the mosquitoes, or protect me from not getting bitten by mosquitoes. So DEET, permethrin, things like that. From a local response, I think it's key to have friends. What does that mean? People that have done this before, you call up and say, what are the lessons learned? Or, hey, we ran out of this. Can I borrow this from you? And you'd be amazed at how easy it is to get people to loan stuff when you really need it. You got to train this all the time. If the first time you're preparing for a disaster is when it's occurring, you're just wrong. And every hospital has an emergency medical response team. I am shocked at the number of times BAMSI's had one. And I'm like, what are y'all really doing? This isn't what we would do. You're wrong. But all the docs, what are we too busy doing? Patient care. We're barely even involved in these conversations, which I think is an issue. Think about the command system. You know, it's going to change. These are very fluid systems. It's the state, it's the police, it's the firemen. All of a sudden now, who is it? Is it the DOD? Is it FEMA? Who's actually in charge really makes this a difficult issue and really has to be done quickly. Patient tracking is a nightmare, especially if you start moving patients, because I moved the patient and then I sent a nurse and a doc with them. Now they're all gone. If I didn't write down that the nurse and doc left too, now all of a sudden I have a missing nurse and doc. How does that go for us? And the family calls and says, where is my spouse? I don't know. You can see how these are going. So you got to sort of be ahead of it. So resupply can be a major issue, especially if you have a short tail. Think about your EMS. Think about your incident briefing. All of these are things that are really sort of vital. So hopefully, as you do all that right, you finish these events and things go well. But there's huge opportunities for after-action reviews to sort of tie up these loose ends. So hopefully I've been able to highlight these things and give you a perspective, at least of what we do in the DoD. And I'll be glad to take questions. Anything?
Thank you, Colonel Murray. It's really outstanding. It makes me afraid, though, now to go into any disaster response.
That's why I believe in interns. You let them go in first, and then you send in the resident, and then the fellow, and the young staff, and the old staff. There's a hierarchy for a reason out there, sir. It really is. The more gray hairs you get, the later you go.
Okay. We have about 2 minutes, and I will, anyone who has a question, an opportunity to ask. Yes.
Hey, Jay.
And FEMA and the military share leadership at all?
Not even a little bit. So FEMA shows they're in charge. And we do that horribly bad, meaning the DOD. We usually have to redirect our folks and say, they're in charge. You can help guide. They're in charge. Now, if it goes really poorly, then you work your chain and they work their chain until you figure out how to do that. But this really ends up being they're in charge. And in the States, just pay attention that, you know, I as an active duty military officer is probably never responding to a U.S. response. The reserves might get activated, but this really ends up being a National Guard. And the National Guard chain of command really is a state chain of command. So the reason that goes pretty well. But once FEMA come in, now I have a federal piece linking the Guard, and that's where we start breaking again. And occasionally active component, reserve component start to be involved in those decisions. But it really can be a struggle. We have huge egos.
There's all this great experience in the military that maybe doesn't have an opportunity.
There's this big law that says I'm not allowed to, which they're really mad about in Texas right now because I think we're practicing down there or something crazy. But those are good. There's reasons there's laws, and there's reasons there's the National Guard, and there's a reason it's a state response versus a federal response. I mean, when you sort of walk it all the way through, this works. I do think you can reach out and talk to us, and we can give you some incredible opinions, oftentimes not formal opinions. But that's the struggle, is you just got to know who to talk to.
Do we have another burning question anywhere? No.